It's my pleasure to introduce our next speaker, ChristianaCare's own Jason Nomura. Jason is a board certified in both internal medicine and emergency medicine. He completed his medical training at the University of Hawaii's John A. Burns School of Medicine in Honolulu, and he completed his combined residency in internal and emergency medicine right here at ChristianaCare. Dr. Nomura is a fellow of the American College of Emergency Physicians, the American College of Physicians, and the American Academy of Emergency Medicine, and is a member of the Society for Academic Emergency Medicine, the American Institute of Ultrasound and Medicine, and the American Stroke Association, and also the Medical Society of Delaware. And Dr. Nomura is going to talk to us today about the treatment of stroke in the emergency department.
Morning, everybody. Guess I gotta use the mic since we have virtual people. Nice to meet you. I'm Jason Nomura. I work here mainly in the emergency department and with the stroke program here at Christiana. So a couple disclosures, I do some ultrasound consulting for Philips, and I've done some stroke research for Bristol Myers Squibb as part of our academic program here at Christiana. So we're going to talk a little bit about stroke in the emergency department and sort of the emergency management there. And just as a preface, we're going to cover some of the things. We can't go into detail in everything just because it's such a broad topic in our short time. But it's very important because, as you know, stroke is one of the leading causes of death and disability in our country. And that's sort of why we're here, with many acute strokes per year, and a lot of them being that first-time stroke. And they're coming through the emergency department. And as we all know, our mantra is always time is brain. So one thing I want to bring up is the stroke chain of survival. So this is something that the American Heart Association, the American Stroke Association has been publicizing, right? We talk about our chain of survival for CPR that you learn in ACLS and BLS, but it's also here for stroke, where we have recognition by the patients and the people in the community, calling 911, getting that medical contact, and then transport to the hospital, and then the last H arriving at the hospital. And then they sort of stop the chain there and assume we'll pick it up from there. So part of it is educating our community so that our patients, our families, and our colleagues are aware of stroke. So you see the FAST information that are publicized widely as a push from the American Stroke Association. And a lot of organizations. Here is a UK example, which seems a little more dramatic than the US example, but it's sort of being used worldwide in different areas to sort of educate the community about what to look for stroke so that you can call 911 either for yourself or for your family member. And then the question becomes, once you've contacted 911 and they've gotten to you and the EMS crew is there, they're going to transport you. But where do they take you? So now that we have sort of the regionalization of stroke care, we have acute stroke ready hospitals, primary stroke centers, comprehensive stroke centers, thrombectomy capable stroke centers. And there's a wide variation in where these centers are located and what kind of resources they have. So the EMS team is there with you, stabilizing that person, but then where do they take you? And that's been sort of the question. So if you look at a map of the US, this is sort of a little bit of the problem. In under 60 minutes by ground or by air, a lot of the densely populated areas can get to a center that can offer TPA for that acute treatment of stroke. But there's still areas where people don't have access to thrombolytic care or rapid care within that 60-minute time frame from EMS contact. And then if you talk about thrombectomy capable centers, we're talking about the comprehensive centers, that availability to our public and to our patients starts shrinking to these very densely populated areas and then huge swaths in the middle of the country that we don't have access to. Luckily for us here today at the DSI, we are pretty good in Delaware. We're sort of in that nice orange chunk where a lot of our community does have access to thrombectomy capable centers within 60 minutes by ground or by air. Which unfortunately, as you know, if the weather's not good, that air transport is severely restricted. So that 60 minutes may not be true for all patients every day throughout the year. So the American Stroke Association has been sort of working along, trying to figure out, once we have a patient with an acute stroke identified in the field or a possible stroke, how do we decide where do we take them? Do we take them to a primary stroke center? Do we take them to the closest hospital? Do we take them to the comprehensive stroke center? And so they sort of come up with some guidelines for routing. Some of them are evidence-based, some of them are consensus. But what it sort of hinges on is this patient possibly having a large vessel occlusion? So is there potentially a large vessel that's occluded where they may benefit and need thrombectomy? And then that's the rub. So you would have to do a pre-hospital LVO screen. And as you can see, there are many, many screens that have been developed and tested and trialed, and their effect is a little variable. So some of them are very good in the population they were tested in, and then not very good when they were tried to repeat it or tried in a different community or a different type of setting. So unfortunately, the large vessel occlusions pre-hospital screens do have their problems. And there's different variability in how well they're diagnosing the large vessel occlusion versus other pathology or even missing those occlusions. So over triage, meaning we've overdiagnosed the possibility of large vessel occlusion, is a little less of a problem for us from the medical community, but they still do miss some. So that under triage is sort of the area where we get concerned about patients potentially not being recognized. From a logistics standpoint, it is a little concerning that if we overdiagnose it in the field, we're possibly routing patients further away from home and routing to certain centers in the exclusion of the centers where they receive their care. So the LVO screen is a little problematic. Currently, we don't have great data, and taking people further away from their homes and families or centers where they receive their care is not ideal either. So once they've sort of decided where they're going to go, now you arrive to the emergency department. We're seeing you at the hospital. And this is where sort of a lot of things start rolling, right? We're going to do the basic emergency medicine. We're going to make sure your airway's intact, you're breathing okay, your circulation is intact, the ABCs of EM care. And then the mantra that's drilled into every ED physician as we're doing our oral boards, right? IV O2 monitor. Patient comes in, airway is intact, breathing is intact, circulation's good, great. Need an IV, need O2, need a monitor. Granted, we're going to try and target a saturation 94% or higher in the stroke patient versus respiratory patients and things like that. We're going to make sure your blood glucose is okay if EMS hasn't already made sure of that. And we're going to sort of drill down to move very quickly in this acute ischemic stroke patient, getting a targeted history. So I'm not going to ask every single question possible, but sort of targeted towards the care of this acute stroke patient. And the most important thing is that last known well time. So, and this is the part where it gets confusing for a lot of times where we're evaluating the patient. When is the last known well? Not when their symptoms were discovered or when they had an event that was recognized, but when was the last time they were known well? If we have patients with people around them, that symptom onset and the last known well are the same time. However, if someone hasn't been seen for a day, we don't necessarily know when the last known well was or when the onset time was. We only know when they were last known well, unless that patient can actively tell us, right? And this is the problem sometimes with wake-up strokes. If you wake up at 8 o'clock in the morning with deficits, that's when we discovered your symptoms, but your last known well is when you went to sleep last, because we don't know, did your stroke symptoms start 5 minutes before you woke up or 5 minutes after you went to sleep? And that time frame is a very important thing when we start talking about therapy options. And then, of course, the clinical course. When that person's problem started, how did it present? And has it been getting better? Has it been getting worse in the time from first onset to arrival at our door? And then other history, previous strokes, whether ischemic or hemorrhagic, and history of intracranial hemorrhages and neurosurgery. And very important is medication and allergies, because if we're going to be going forward with imaging and other things, we need to know about allergies, anaphylaxis, and things like that. And the key thing is the anticoagulation. Are they on Coumadin? And if they are, we'll have to check out INR. Are they on a novel oral anticoagulant? And if they are, when was the last dose? Because unfortunately, right now, we can't get rapid testing for the efficacy and the levels of these drugs in most centers. So we have to go based on a time base. When did you last take that medication? When did you last take your Pixaban? And then, of course, we're going to do a little bit of testing here. Is your INR greater than 1.7 if you're on Coumadin? And ideally, if you can get a point of care, you can get that information much more rapidly. And the direct oral anticoagulant, did you have a dose less than 48 hours? Because these are sort of the things that take us out of the TPA window and the thrombolytic category. Recent strokes or MIs, bleeding risks, and there's a lot of information we're going to have to track down. And unless you're doing this all the time and these things are just rolling off your tongue, which for a lot of us it's not, because we're seeing a lot of different things, use a reference. That we have them out there, they're electronic, they're paper, they have all the contraindications, the relative contraindications, and all the important historical facts we're going to have to go. And in the effort of moving quickly and rapidly for the care of our patient, it's hard sometimes to remember all the finer details in the heat of the moment, so having references are always helpful. And then we're going to roll into our neurologic exam for that patient. And the thing that we all know about, the NIH stroke scale, right? A validated scale that's been being used internationally for many, many years, both in research and patient care. And then there is the official one that you can download from the NIH, which are multiple pages long with the images that you can show patients, some of which appear a little dated if you've seen the original document. And if you've done the online training, there's Dr. Leiden who those kind of fuzzy videos from way back when. He does not quite look like that anymore, but you can watch these videos and he takes you through with actual stroke patients with deficits, and then you can learn how to assess and score the exam. And then we're going to have our NIH stroke scale. And this is sort of our algorithm here at Christiana. It's very busy, a lot of moving parts and a lot of things going on. But the thing I want to highlight is this is sort of what we're doing for our stroke patients. But the key thing here is that it is a team effort, right? The nurses are engaged, the unit clerks are engaged, our CT technologists, our physicians in the ED, our neurologists, our radiologists, our interventionalists. We're all sort of coming together to have this an acute event to take care of this patient. So the issue is that it's all of us working together. Any single person not being able to attend is going to impact our ability to care for that patient. So it's not the physician alone, it's not the neurology alone, it's all of us together working to try and expedite things as much as we can, right? Every part of the ED, every part of radiology and neurology come together to make this happen. And then we're going to roll them, once we've done all of this, we're going to roll over towards imaging. And our standard is the non-contrast head CT, right? We're going to get a non-contrast head CT because it's quick and it's available and we can get the information we need. We're really going there mainly to rule out things like subarachnoid hemorrhage or intraparenchymal hemorrhage, right? We're ruling these things out to see if we can proceed with therapy. We may not even see signs of an acute stroke like this where we see that hypodensity. What we're really, clicked a little too quickly. What we're looking for really is maybe some subtle signs of stroke or really a negative head CT, right? That negative head CT does not tell me there is no stroke. What that tells me is there's no hemorrhage and there's no subacute or a chronic stroke. So what I'm really looking for is a negative CT. The negative CT does not rule out acute ischemic stroke. And now in this day and age, we also have different programs that can help with some automated interpretation. And as you can see, they will flat out tell you this is not for primary diagnosis. This is an assistive device. So this AI algorithm can take those CT images and tell me, yes, there is a suspected hemorrhage. And this is great. If I have a radiologist on call who can look at my images in real time as they're acquired, that's wonderful. But that's not the usual case across the country and in every hospital. And you could see like in the map where we had access to thrombolytics, there's a little different variation in our access to care for our patients and our communities across the country. So some of these automated tools will help people who may not have the same resources that we do here in Delaware. There are also automated reports for things like the aspect scores to look at that non-contrast CT and look at the risk of acute stroke. And then once we've sort of gotten our imaging, our history, and all this information, we sort of have to reach our treatment decision. And at that point, like, you know, time is brain. The faster we take care of this, the faster it is, and the better it is for our patient. Time is brain is the mantra that comes across in all our literature. It's even the name of some conferences. And the reason that is if you look at the data, the faster we get them from door or onset to treatment, the better results the patients have. So less than 45 minutes, they had less mortality and less readmissions for stroke patients. A little busy graph, but the faster we got the patients treated, the more likely they were to have reduced in-hospital mortality, less hemorrhage. They were more likely to ambulate independently at discharge, meaning going home and not having an assistive device. And they had an increased chance of being discharged home for every 15-minute increments less to TPA. So that's sort of why we've been pushing for that increased time to treatment. And in some countries, they've been able to do what's called the Helsinki model. And I don't intend for you to read this, but they've replicated it in Australia. And part of this is you can see that there's a multimodal and multi-team approach to make this happen, from identification, imaging standpoint, and physician standpoint. And they were able to reduce their door-to-needle time quite significantly over time as they implemented all these different things and reiterated the process to keep improving and driving that door-to-needle time down. And the American Stroke Association recognizes this. This is why there's that target stroke program where they want you to get door to needle times faster and faster for more and more of your patients. And they start adding like extra words like, you know, you have target stroke, then you have honor roll, then honor roll elite, and then honor roll elite plus. But really it's driving us to do performance improvement and get that door to needle time down as much as we can to help our patients. And the treatment for us, in most cases in the emergency department, in most centers, is going to be systemic thrombolytics. And we'll get back to why I'm phrasing it that way. And really, we're targeting the patients who have been last known well less than 4.5 hours. Right? If you look at the FDA labeling for TPA, and you remember many years ago, we only went up to 3 hours. And then we were able to expand the window from 3 to 4.5 hour window with some caveats. So you may still see this listed somewhere where there are additional warnings in that 3 to 4.5 hour window. And some of these warnings are not necessarily panned out in the literature. The reason this happens, and from a historical perspective, is that extended window trials were done mostly in Europe, where the labeling is a little different than they are in the US. So these extra items are sort of on the equivalent of FDA labeling for TPA in Europe compared to the US labeling. So most of these are should raise your concern about an increased risk of hemorrhage, but are no longer exclusions. So we're up to that 4.5 hour window. And the people we're targeting are those people who have a disabling deficit. And that deficit sort of has to be disabling. That's the key word here. We're not relying necessarily on a number anymore. It's just the disabling deficit. Is that patient disabled? So a 35-year-old with some weakness in their dominant hand with a manual job, that is much more disabling than an 80-year-old who has wheelchair bound with a little increased numbness in the leg that they are unable to ambulate on, right? That little difference makes a huge difference in the disability for that patient. And so that decision has to be sort of centered around the person and what they're doing and how this deficit will affect them. And then we move on to our agent. Our general agent is alteplase. 0.9 milligrams per kilogram, 10% as a bolus, 90% as an infusion, easy to roll off the tongue, hard to calculate in the moment while you're being rushed. Use a dosing table. Most centers now are moving to dosing algorithms unless your EMR is calculating it for you. I can pick the weight, pick the dose. I don't have to calculate out my dose and then my 10% and then figure out my drip rate. The more things you are calculating or figuring out independently on the fly, more prone to errors. And TPA is, alteplase is not easy to mix. It's a large vial. You have to mix it in a certain way. It's a little finicky. You can't shake. You have to swirl. You have to wait for the bubbles to go away. It's not fast. So one of the things that we will do is pre-mix. If you think you're going to need it, you can pre-mix it so you have it ready to administer as soon as it's appropriate for the patient. And the companies do allow you to return pre-mixed vials that have not been utilized if you complete the paperwork for stroke. But this saves a lot of time rather than making the decision, then starting to mix to have that drug ready by pre-mixing. And of course, we have to achieve blood pressure control, right? Our goal for the bolus is less than 185 over 110. During the infusion, 180 over 105. That's always been a little bit of a sticky point that, you know, we have two different blood pressure targets that are going to be used a minute apart, but I generally target the 180 over 105, achieving it with beta blockade or calcium channel blockers to get that pressure down and keep it under control. And the blood pressure is very important. We have to keep that blood pressure under control to reduce the risk of hemorrhagic conversion once we're starting systemic thrombolytics. These drugs are very powerful and not without risks, which is why we really focus on blood pressure control. And then you're going to have a lot of vital signs and neurochecks. It's going to be a very intensive process for our nursing staff. So that's the other thing, making sure we have the nursing staff to be able to continue to care for that acute stroke patient and everything else that's rolling through the door, whether it's a trauma or a STEMI or someone who has pneumonia. Now, from the provider group, I know we have a mixed audience, but one of the things that has been coming up is the use of tenecteplase in acute stroke. So when we're talking about systemic thrombolytics, alteplase has been what we've been using for years, for decades. But tenecteplase is sort of on the market now, or sort of coming into stroke care now. It is utilized for acute STEMI care, so we use it quite often. But for stroke care, it's sort of the new thing on the block. And while it's new, it's not that new. So if you look at the American Stroke Association guidelines from 2019, that's when the study started to come out that tenecteplase may actually be better for our patients going for mechanical thrombectomy. So we are potentially achieving better rates of recanalization, decreased deficits in patients who need a mechanical thrombectomy for large vessel occlusion with tenecteplase compared to alteplase. And then they said for those patients who are not going to mechanical thrombectomy, it's reasonable to consider tenecteplase. Very weak recommendation. They're like, you're okay if you do, you're okay if you don't. Up to you. And at that point, back in 2019, they were looking at the 0.4 milligram per kilogram dose, a little higher dose, which has sort of fallen away based on the trials that have gone on since then in the last 3 years. So when you look at the trials, the NORTEST trial looked at tenecteplase, the 0.25 milligrams per kilogram treatment, and we had improved recanalization and decreased deficits for those patients who went on to mechanical thrombectomy. That's the caveat. And then when you look at the Extend IA-TNK trial, same thing. So all of these patients were doing better with tenecteplase if they were also getting mechanical thrombectomy. Now, the patients that did not get thrombectomy seem to do okay with tenecteplase. Now, the real data is for those patients, when you look at the TNK trials for mechanical thrombectomy, it clearly favors improvement in patient outcomes with tenecteplase. You can see that the bars are clearly away from 1 there for both outcome, deficits, and hemorrhage risk. So the dosing in stroke is 0.25 milligrams per kilogram with a max of 25 milligrams. The data has shown that for the patients who don't get mechanical thrombectomy, they don't necessarily do better, but they don't do worse than alteplase, and they don't have more risk than alteplase. So some of those things about the mixing and the handling and the drip and stuff, logistically, tenecteplase is much easier. It's a single bolus. I mix it quickly, I give the dose, and we're done. So if we're doing better for our mechanical thrombectomy patients, that's easy. However, for our non-thrombectomy patients, choosing between 2 different drugs and making a decision, are you going to get a thrombectomy now? Am I going to decide in 10 minutes? Do I wait? Having a single agent is logistically better for the system and better for patient care. And they're not doing worse if they don't go for mechanical thrombectomy, and they're not having worse outcomes. So that's why most centers are now starting to transition. And ongoing data that's being presented at conferences as interim analyses do show that patients are doing just as well on tenecteplase without thrombectomy as they did on alteplase. And of course, we're going to hold antiplatelets and we're going to hold anticoagulation if you get thrombolytics. And the other caveat is our quote unquote minor stroke, right? So the medical literature calls it a minor stroke, but no stroke is really minor for our patients. With whatever deficits they're having, it's going to affect their life. But these are the patients that don't qualify for alteplase or tenecteplase, right? That deficit is not necessarily disabling, or they presented a little bit outside the time window. And what they're saying is in that population, we do have another treatment option to prevent, not necessarily to treat that acute stroke, but to prevent the recurrent stroke that they're at risk for in the acute and long term. And so if their stroke scale is less than 3, which is what the trials are including, we do have the option of dual antiplatelet. And we can see with the dual antiplatelet trial, there is decreased risk of recurrent stroke. There is a little increased risk of bleeding because we are adding on a second antiplatelet agent. But when we look at the data, some of that bleeding risk is a little bit more towards ticagrelor rather than clopidogrel, which were the early studies, faster chance and point. And as a side note, Delaware did participate in the point trial. So we can see that the patients do better on dual antiplatelet. There is a little bit of increased risk for ticagrelor, so more people are using aspirin and clopidogrel as their dual antiplatelet choice. Starting the load in the ED, 325 plus 300. If they pass their swallow eval, right? These are all oral agents. They have to be able to swallow to get the medicines, and then continuing them on that dual antiplatelet therapy for several weeks. Now, the other part is going in the opposite direction. We have our patients who are getting systemic thrombolytics if they're in that medium area, disabled within 4.5-hour window. We have the dual antiplatelet for the patients at high risk who are on the lower end, but on the greater end are those less large vessel occlusion patients. And that's not really the ED stroke treatment side. We do have a speaker later talking about that, but from the ED, I do have to diagnose that, right? Because I have to call my interventionalist and let them know what's going on. Maybe on your non-contrast head CT, you're seeing what's called a hyperdense sign, where I see thrombus within that middle cerebral artery. Or I'm getting my CT angiogram and I'm seeing the definite cutoff. I'm seeing the contrast not reaching that middle cerebral artery, whether it's on my axial images or on my fancy 3D reconstruction with the occlusion right there. Or I'm using some of that automated processes for places where I don't have neuroradiology on at night, where I'm using that automated process to try and diagnose that occlusion there in that MCA, where it's kind of telling me, hey, there's a risk for occlusion there and there's a concern. Or I'm looking at perfusion. So I have patients that are potentially outside of the thrombolytic window who may benefit, where I have to look at the cerebral perfusion about how much of brain is infarcted and dead, where I can't do anything about that, but how much is penumbra, how much is at risk for further worsening and becoming an infarct that I could potentially salvage. And the reason for this is if I'm at a thrombectomy center, I can potentially take them to thrombectomy. If I'm not at a thrombectomy center, the sooner I have that information, the sooner I can make a decision to transport them, right? Because I have to get them to where I can provide the therapy that I need to, or to someone that can provide that therapy. And if it's not at my hospital, I have to get them where they can go, whether it's by air or by ground. But the sooner I know there's a treatment that is available for that patient that I can provide, the sooner I can start the wheels rolling on that transport, whether it's by ground or air. And that's also why the Joint Commission and some other groups are focusing on the door in and door out time. If I'm transferring patients, when did they arrive at my facility and how soon did I make a decision to get them out of my facility to a higher level of care? So thank you very much. We'll have another speaker who's talking about large vessel occlusion. And if there's any questions, you can always email me.
Thank you. It sounds like you do the non-contrast head CT and the CTA at the same time, rather than take a break and see whether they get IV thrombolytics. Is that right?
Here at Christiana, we do the CT and the CTA in one swoop. If they are eligible for thrombolytics, we will pause between the non-contrast and the CTA to start thrombolytic therapy. But while they are in CT on the scanner, we don't remove them from CT and then come back. We just get the non-contrast, make our decision, initiate treatment, and then get the CTA. Unless there's a clear reason not to, like, anaphylaxis to contrast, or we know that they have certain, or they've recently had an MRA for some other reasons, and we know that there's certain findings or things like that. We found over the time that stroke has been a little tricky. So we've had patients where we don't expect a large vessel occlusion, and then we find them. And then, a lot of those patients, if we didn't find that occlusion, 2 hours later, their NIH stroke scale is skyrocketing and they're doing much worse. So in many times we found that it's probably better overall for the patients as a group to go ahead with the CT angiogram.